marijuana use. It impairs their ability to make clinical decisions, to provide informed consent. And at the end of the day, if there's a liability issue, you will be culpable knowing that you had a patient under the influence. And it was self-medicating. We used to approach the conversation with decisiveness. You've gathered enough information from whoever observed the behavior. You trust your staff because they've been trained on how to suspect or recognize some clues associated with being under the influence. So that's where you don't undermine the staff, and you approach it with just a decisiveness. We're going to reschedule the appointment today. I don't like that word addict because it's not appropriate, but these are someone's mom and dad. These are someone's brother and sister. This is someone's husband and wife. They're much more than the disease of addiction. And so I think what's happened in our society is that addiction has such a stigma, such a negative connotation that nobody really wants to talk about it. And these individuals, they're suffering in silence.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, an Endeavor Business Media production. This is episode number 375, and I'm your host, Andrew Johnston. Thank you so much for being with me today. Lots to talk about in today's intro. So first things first, we have on the incredible Dr. Ronni Brown for the episode today. And she talks about treating patients who have a current or maybe a history of substance abuse. And we navigate the tough conversation that sometimes needs to be had with those patients, and she just does it so expertly. So you're gonna love her so much. And then next week we have a shorter episode, a quick episode, which is basically an intro to salivary diagnostics. You'll hear me mention it in that episode, but I can't stress it enough that I know absolutely nothing about salivary diagnostics. And so this truly was an intro, like, hey, Andrew, this is what it is. And I feel like a lot of you are in that same boat, because at the conferences, I'm seeing that topic more and more. And I think that hygienists are becoming more aware of it. And so I kind of wanted to just give this to you, like, as a little teaser and a taster for salivary diagnostics. But hopefully we'll have back Carrie Lepacek as she can dive a little bit deeper on when I learn more about it. Now, what I really want to get into on this little intro is the vacation I just had. And I say vacation, but I mean, it's hard to turn your brain off, if you know what I'm talking about. And so I want to preface this by saying that I acknowledge that there are so many clinical hygienists out there who do not get any sort of real vacation. And when they do, it's because the doctor chose the time that they're going to take the time off. And it may or may not be a paid vacation. It might be just a forced vacation. And that was me. That was me for a dozen or so years. You know, I was telling you before, I've worked, 40 to 60 hour work weeks for almost 10 years straight. And I would take an occasional long weekend because I did 10-hour shifts. So I did 4 10s. And so occasionally I just wouldn't pick up an extra shift, but that's not really a vacation, so to speak. I never really went anywhere. I didn't really do anything. I didn't do anything to like really turn off my brain. And so then in 2015, when we started the podcast, even when I was away at like a conference or something, it was always work. Even when I was out gallivanting the globe, we always had, an intro to do or an interview to do. It always felt like there was just something going on. But this week, I took a solid 3 days, 3 full complete days where I was completely out of communication with the world. And when I mean completely, I mean mostly, because we were in the middle of nowhere and I would get like little spots of signal here and there, just kind of send a quick Facebook message, but essentially off the grid. And so in 2020, I don't know if you guys remember this, but my sons and I were supposed to go to the Philippines on a trip. And the point of that trip was a boys' trip. It was to say, hey, sons, this is where I had lived. I love this country so much. I want to show this to you. But that was in March of 2020. And literally it was the week that the world shut down is when we were supposed to go. And so we put it on the back burner. We were going to try and do it last year. It didn't work out. We did end up going to the Philippines last year, but again, it was a work-related trip. And then now my sons, 16 and 14, were able to go. We did it on their spring break. And I think it was actually better that they're a little bit older. And it totally worked out. It was so much fun. So not only did I take them to the Philippines for the spring break, but we did an island hopping adventure on a boat that they call a bangka. You'll probably have to Google that one, but it's a really cool little boat that has like a double outrigger for stability and like a tiny motor and just like plugs along in the ocean. So we started in the small island of Coron and we made our way to another island called Palawan about 3 days later. And each day we would stop at 2 to 3 tiny little islands that had a really cool beach. There's usually some sort of snorkeling in this crystal clear water. It was just the most amazing agenda ever. We saw coral. We saw all sorts of sea life. At night, we stayed in these little huts next to the water. They cooked us traditional Filipino meals, and our journey was shared. We had on this bunga, I think there was 14 of us. There were people from Brazil, Slovenia, Norway, Holland, and then I think us, the Americans. And pretty much it was as close to perfect as you can get. It really did feel like I was able to completely relax and have a good vacation. And I only thought about work a handful of times. And when I thought about work, here's what I thought about. And the reason why I tell you this, I guess, was because there was one of our stops, we did a tour of this little town, a little Filipino town in the middle, literally in the middle of nowhere. And I thought, how incredible would it be? I've been searching for a place to do a dental mission. How incredible would it be to partner with this amazing crew that takes us to all these little islands, but then also we could do a dental mission trip. And the cool thing about the Philippines is it's not that expensive to do a trip there. And so I feel like, if we can get the team together and we can get all the supplies, this would be the most amazing, affordable dental mission trip I think that almost anyone has ever been able to do. And also just the most amazing scenery. But other than that little fact, I was able to really just enjoy my time. It was an incredible experience. I'll have memories for forever with my amazing 2 children. Next year, I hope to have amazing memories with my third child in the Philippines as well. And one thing I also want to kind of share, and I think that you guys all probably know this, and it's just me being dumb and just figuring this kind of stuff out, but it's a real wake-up call that I just need to do better at juggling work and life. It has been way too many years. I mean, it's been not quite really 2 decades, but it's been almost decades worth of prioritizing work and life ambitions ahead of kind of my real life. And I just need to do better. I need to make more opportunities to create memories with those that I love. And I hope that, obviously I say that just because I'm hoping that if you're hearing this and you're someone that's ambitiously driven, kind of like I have been for so long, that you can also kind of like learn that lesson in a way that's not quite so hard than I think what other people experience. So essentially, I want you to excel in the op and just love your life outside of it as well. Okay, so with that, I hope you really enjoyed this episode with Dr. Ronni Brown.
A tale of 2 hygienists.
So you did 2 courses yesterday, right?
I did Treating Between the Lines, which is my kind of overview of substance use disorders and oral health. I had a standing room. People were sitting on the floor.
Of course.
And then and it was great. Interactive audience, great questions. And then my second course is Pulp Fiction or Evidence-Based Dentistry. How do you transform your practice with science? It was a smaller group, but it kind of felt like a seminar, like a workshop. Yeah. And it was kind of hands-on. So they were pulling out their phones, learning how to navigate PubMed and the Cochrane Library and the CHIP database to find really high-quality evidence.
Yeah.
But it was great. It was a really good audience.
Well, that's good. What kind of questions were they asking you in that first course? What were those good questions you're saying?
Definitely questions about in that moment. When you have suspicions about a patient, what do you do? What do you say?
Good, because that's what we're talking about today. So
exactly.
You're all warmed up for that one.
Exactly. And definitely questions about, even though the course doesn't talk about marijuana, the prevalence of marijuana use amongst patient populations. And I think people really feel it's like a lesser effect, so we can just kind of ignore it. But at the end of the day, someone's under the influence.
Yeah.
So I really had to kind of hold that firm line with the audience that a patient's impaired.
Yeah.
It impairs their ability to make clinical decisions, to provide informed consent. And at the end of the day, if there's a liability issue, you will be culpable. Yeah. Knowing that you had a patient under the influence. And it was self-medicating.
Because you don't think about that as a clinician. You're like, oh, this is going to be so much just a more chill appointment. Like, this is going to be great for us. Like,
right.
We can just get the work done quick and get them out the door and do all these things. But yeah, there's a whole liability thing.
The patient's self-medicating. And the reality is you don't know what else they might be self-medicating with. Mm-hmm. And it's very different when we give the patient, a milligram of Ativan or 5 milligrams of Valium. We're dosing it based upon the procedure, the length of time, the onset of effect. But when someone self-medicates, it's kind of a open field. You have no idea what's going on.
Yeah.
So
Yeah.
I kind of had to hold a little bit of hard lines. I think people want to wiggle a little bit around
Absolutely.
it, and they don't want to confront it. But we have to confront it because we've got this massive substance use disorder in our in our country. We've got to start dealing with it. So.
We were walking down Michigan Avenue yesterday, and that's one of the things that Erica was saying.
It's like a lot of pot.
Marijuana there, marijuana there, marijuana there.
Yeah.
It's prevalent. Like you just can't get around it. I feel for the business owners though. Like I feel like, oh gosh, our hygienists are so sick of me talking about business all the time. But I feel for the business owners because you do have, like, if you have to reappoint that visit, then
Right.
that's lost income. That's
Right.
The DSOs can probably absorb that loss, but the independent practices it's hard to
But I think if
make that
you
decision.
create the culture of what's acceptable in your practice, and I talk a lot about office policy and making it really transparent for the entire staff about we will reschedule patients under the influence, letting your patients know up front as one of the office forms that they fill out. There's a policy about patients under the influence that they will be rescheduled. If you create that as the culture and you're trying to create what's acceptable, right? Like no-shows, not acceptable if you're more than 15 minutes late, right?
Right.
So if you create kind of what is acceptable, you are retraining your patient population. Now, some patients may choose to walk away, and that's okay. They may be patients you don't want in your practice anyway.
Right.
But it's about really kind of creating the culture so that you are maintaining patient safety at all times.
Well, and when you're dosing someone, you're getting the informed consent before you're
Absolutely.
putting them under the influence. So
Absolutely.
Yeah.
Absolutely.
With that policy, because these forms are so long now. How many times have our patients complained about how long their medical dental histories are and all these things? Is this something that's like highlighted in, it's bolded in the policy manual? Like, how do you get the patients to actually read that part of it, though?
Well, I think the office policy really is about a paragraph. Like if a patient is suspected to be under the influence of a controlled substance by the treating dentist, that patient will be rescheduled and is to return ready and sober for care because there's concerns about drug-to-drug interactions, ability to comply with post-op instructions, accuracy of health information, and behavioral issues. Boom. Sign, date. Patient keeps a copy, you keep a copy in your electronic health record. Now, no different from the financial policy that they sign, the no-show policy that they
also
sign.
don't read, but yeah.
Right, but it creates, when you have an office policy, it creates a degree of objectivity. Like, it's not personal. I'm not saying that you can't come in and be treated, Andrew, because I don't like you. It's just like, this is our policy for all of our patients.
Right.
It's
Yeah.
our ethical and professional responsibility.
Yeah. So, okay, let's get into like the kind of more communication side of things. So, a patient walks into the office. I would say, whose responsibility is it to start suspecting that there's substance abuse? Is it right from the front? I mean, are we expecting our non-clinical staff to make that judgment and pay attention to that, or is it now the dental assistant, the hygienist, or the doctor?
I think it's all of the above. I think, we want to train our front office staff not to make the judgment, but to be aware of the physical and the behavioral clues that are associated with a substance use disorder. They are the first eyes and ears that the office has to that patient, right? They're observing the patient's behavior in the waiting room. That patient's walking up and filling that form. So if the patient's behavior seems to be out of character, they seem extremely lethargic, which might be a clue of opioid use, or they seem extremely manic, which could be a symbol of stimulant abuse, or they smell like alcohol when they go up front, they need to then alert the dentist. And the dentist needs to be alerted because the dentist is the authority figure in the practice. The dentist then needs to, and one thing I kind of tell the audience is, one thing that we're good at doing as dentists is undermining our staff.
Everything looks good here. There's no perio. Don't worry about it. There's full-blown perio.
Yeah, exactly, right? And so I want to speak directly to the dentist. We have to stop doing that because we
Amen.
rely on our staff to have our back. I mean, my dental assistant is always telling me, Dr. Brown, I have your back. And so we need to make sure that we have our staff's back. Now, if they present to us with some concerns, we need to figure out what those concerns are. What did you observe? What did you smell? What brought that level of concern to your attention? So we have to first train them as to kind of what to look out for. And we're just looking for a suspicion. The dentist then can kind of, put it together. But then the dentist is the one who needs to have the conversation because that dentist is the authority figure in the practice and needs to state, I smell alcohol in your breath. This presents some concerns for me. I want to reschedule your appointment. We have an office policy. Let me walk you up front and get that appointment rescheduled. And then always end with a statement of caring, like, is everything okay? What's going on? It could be a simple mistake, like I had a business lunch, had a glass of wine, and then I got a beep from my phone and remind me of my 2:30 hygiene appointment.
And then they ran right over and
Sure.
Or it could be something catastrophic. My wife just called me and told me she's filing for divorce. You don't know, but I think it's always important to end with that statement of caring, to let the patient know that you care. It might be just kind of a one-off situation versus a repetitive situation, but definitely I think from the front office to the back office, everyone needs to be on the same page. And that's why you need to have an office policy in place where everybody knows exactly what is going to happen if a patient walks in under the influence. Because when it's unclear, because oftentimes the dentist, the authority figure, does not communicate their own professional responsibilities in the situation. And when they don't communicate to their staff is unaware.
We don't know, yeah.
And so it creates this swirl of confusion where everyone is whispering, right? Everyone is mumbling. And then you start justifying things like, well, it will just be a quick appointment. Yeah. We're just cleaning the teeth.
It's just a polish. It's
just a polish.
It's a fluoride varnish.
It's just adjust, right?
Sure.
But that just could be a patient experiencing an opioid overdose in your chair. That just could be that patient's impaired, gets behind the wheel of a car and hits a child crossing the street. I mean, it's not a just.
Yeah.
And so we have to make sure that our entire staff knows what the expectation is so that everyone's really clear. If we have clarity, everyone knows how to respond. And then when you approach the patient with a degree of clarity and decisiveness, you also minimize that opportunity to have that patient coax you into treating them. Which will happen if you don't approach it with a bit of decisiveness and a bit of clarity.
I'm jumping ahead a little bit in this one thing, but we're talking about the suspicion still at this point.
Yeah.
Let's say that conversation goes and you're, as a dentist, you're like, I don't really know. They're probably just fine, but there's maybe a whiff or just a small little hint somewhere that you're like, well, but probably not. Do you document that in a legal record?
Absolutely. Always document your suspicion. And at the end of the day, even if your suspicion is wrong, it's okay.
And there's no blowback that can come from that?
No, not from a malpractice perspective. As long as you document the suspicion. I smelled alcohol in the patient's breath. The patient's behavior was out of character as demonstrated by this. As long as you document it. Because one question that I got yesterday was, I don't want to be perceived as like profiling or like being prejudiced, right?
Yeah.
And I think, one, if you have an office policy in place, it minimizes that degree of profiling because you have a policy that applies to every patient, regardless of their gender, their sex, their culture, their socioeconomics, their insurance status, right? And so that creates a level playing field for all of your patients. You might be wrong, but it's better to be wrong in this situation than to be wrong in a situation where you're calling 911.
Yeah, no, 100%.
Well, and when you discuss it with the patient and they say, no, I'm not under the influence, but you really believe that they are, I mean, what do you do?
Sometimes I think, and that's a really good question, that sometimes you're not asking, are you under the influence?
You're just saying,
sometimes you're saying that, I'm concerned, your behavior seems a little bit problematic. My front office noticed a smell of alcohol in your breath. And I think we just really need to reschedule this appointment today.
Perfect.
Because I have really some concerns and I'm going to operate off of my gut feeling. I mean, we have a gut feeling for a reason because it keeps us safe, right?
Yeah.
And typically we're probably the only species, if you look at, giraffes, if they see a lion in the woods, they're not running towards the lion, they're running away, right?
Yeah.
We're the only one that runs towards danger.
So you don't leave space for the denial.
I think you approach the conversation with decisiveness. You've gathered enough information from whoever observed the behavior. You trust your staff because they've been trained on how to suspect or recognize some clues associated with being under the influence. So that's where you don't undermine the staff. And you approach it with just a decisiveness. We're going to reschedule the appointment today.
And I know we've talked about this a couple of times already in just this short little bit, but can we just do a quick little role play with that?
Sure.
Only because here's the thing: I'm a parent of a person, and if I was a person that's ultimately responsible for this, I don't want to mess this up.
Right.
So I'll be the patient under the influence.
Okay.
I'm great with that role. I'm just kidding, Dad. I'm not. No.
We won't tell.
Okay, so the same scenario. The front office has a suspicion about me. as a little side note, at that point, are we still taking X-rays if it's a checkup, or we're not even doing X-rays?
Sorry. We'll role play.
Okay.
But let me kind of walk you through the scenario before the role play. Is that okay?
Let's do that. Yes,
Okay.
yes.
So the conversation needs to have 5 elements. The first is you need to be decisive.
Mm-hmm.
Decision's been made.
Mm-hmm.
The second thing, you need to be honest, and you need to state the reason why. You need to be fair. I'm not dismissing you from the practice. We're just going to reschedule. So you're honoring the relationship that you have with the patient.
Mm-hmm.
You need to be ethical, state why this situation does present some professional ethical concerns, and then you need to be caring. So those are kind of the 5 elements of the conversation that I'll demonstrate. Now, in terms of, kind of just walking you through the scenario, the patient arrives, the front office smells whiff of marijuana and alcohol and a vinegary smell, which might
Wow,
be heroin.
you are really giving me some stuff.
Okay.
Okay.
Yeah. So you're just
okay.
you're loaded.
I am
You're
feeling
loaded,
good right now.
okay?
Okay.
You're ready for your dental appointment,
I'm
right?
ready for it.
'Cause-
No more anxiety. I'll
No
tell you
more
what.
anxiety,
Give me
right?
all the drill and all the shots that you need. I got this.
Yeah, and you're slumped up against the front office desk.
Yes, that's right.
Okay. So the front office, because they've been trained, goes to the dentist who's sitting in the office and says, you know what, I'm really worried about Andrew. He's been a patient in practice for years. Something's really off with him, and this is what I observe.
Mm-hmm.
And based upon what the front office is saying, the dentist should say, this sounds like he's under the influence. So don't bring Andrew into the operatory.
Sure.
Because once you bring a patient into the operatory, they have an expectation that they're going to be treated, right? So you want to, if the waiting room is empty, you want to have the conversation there. If you can bring the patient into a consultation room, bring the patient there. But don't bid the patient up, put the glasses on, have the anesthetic syringe right there, because now you have to manage a different degree of expectation.
Yes.
Okay? The dentist should recruit another person to be present, one as a witness to the conversation, but also when someone else is present, it tends to actually de-escalate the situation. So then you go through that, decisiveness, fairness, honesty, ethical issues, and caring. And then you say, this is what we're going to do. So you're really kind of taking charge. This is what we're going to do, Andrew. I'm going to walk you up front. We're going to reschedule your appointment. I'm going to call your emergency contacts for someone to pick you up. Because once again, there is liability if you let that patient go and they get behind the wheel of a car. And then you end with that statement of caring. So that would be kind of how I'd walk you through. Yeah. So let's say, Erica, you are the front office person. I'll be the doctor, and you'll be the patient.
Absolutely.
Okay. Dr. Brown, Andrew's in today, and he's just not his normal self. I smell alcohol. Are
you sure?
Yeah, I can smell marijuana, and he's kind of slumping over next to the desk and looking very tired, and I'm a little bit concerned.
This is pretty unusual for Andrew because he's been a patient in practice for years. Did you, when he was talking to you, did it feel like his speech was slurred?
Definitely. And when I was speaking to him, I don't think really anything was getting in. He wasn't understanding what I was really talking to him about what we're going to do today. And I just definitely, my gut is telling me that something's going on.
Did he come with somebody else or did he come by himself?
He's alone.
Okay.
There's no one in the waiting room.
Okay.
But if you'd like me to come with you, I can be there for support.
Yeah, I think we probably need to have a conversation with Andrew. It doesn't sound like he is, this would be safe to proceed with treatment today. So let me go and let's go together. Let's go into the waiting room. Let's have that conversation with Andrew. And then I'm going to ask that you kind of serve as a witness to the conversation. And when we're done, I want you to definitely document what your suspicions were, and they definitely sound reasonable.
Okay.
All right.
And I'm going to let you take the lead on this when we go out there.
Perfect. Okay. So I'm walking out into the waiting room, and Andrew I'm just like sharing what I've observed, but definitely he looks like he's out of it.
Yeah, he sure does.
Yeah. Andrew. Hi, Andrew. Dr. Brown. Yeah.
Doctor.
So, Andrew, I think we need to reschedule your appointment today, okay? Yeah.
No.
Yeah.
Here.
Yeah, I know, Andrew. I know that you came, and I appreciate that. But definitely, something seems definitely off with you today. So we are going to reschedule your appointment.
Never felt better, doctor.
Yeah, Andrew. We smell alcohol in your breath. We also smell marijuana, and your behavior is just very.
It's from last night.
Yeah, I know, very atypical. But this is a concern for us because. It really impacts my ability to provide you with safe care. It impacts my ability to be able to validate that you understand the procedure that we're going to be doing today, which is that root canal in tooth number 14, and to be able to provide you informed consent. And more importantly, our job is to keep you safe. So we are going to reschedule the appointment today.
I'll be your best patient, doctor.
I know, Andrew, I know, but we are going to reschedule. And I do want to remind you, Andrew, of our office policy, that we will reschedule patients that we are concerned about that might be under the influence. But this is what we're going to do, Andrew. I'm going to walk you up front. Erica's going to reschedule your appointment. Erica, we're going to call the emergency contact that's listed in the health history form.
Definitely.
And Andrew, it's really important that when you come back for your appointment that you come back sober, ready for care. If we suspect that there's any substances in your system, we are going to need to reschedule that appointment. Our job is to make sure that we keep you safe. We care about all of our patients. We want this to be a wonderful experience for you, but we've got our first and foremost priority is your safety. And then Andrew, tell me, is everything okay? This is a little bit unlike you.
Oh, yeah. Doctor, it's fine. Everything's fine. Great. I wish this was a video podcast, by the way. You did amazing.
You did too, slump it over.
I don't know how to be. Am I supposed to be high or drunk or like?
You all the above, Andrew.
I don't know what does that sound like? I'll just do like depressed sounding. I don't know.
But you said some very realistic things to Dr. Brown about, well, it's from last night, or I'm actually fine.
Stuff we actually do here. We've heard that before.
Yeah. And the thing that is important is that all of these drugs have different half-lives, right? And so even though it was last night, let's say you were on methamphetamine, the half-life of methamphetamine is about 10 to 12 hours. It takes 4 half-lives for 90% of the drug to be eliminated from the body. So think about 4 times 10 to 12 hours is 40 to 48 hours. Sometimes it takes 2 days for it to clear your system. So even though it was last night, that doesn't necessarily mean that you don't have the drugs in your system and have some degree of impairment.
Can we talk about the call to the emergency contact? What does that sound like?
So I think the call to the emergency contact is just literally, Andrew is here. He's under the influence. We do not want him to leave and get behind the wheel of a car or injure himself or somebody else. So we are going to have Andrew sit in our office, and we have called you so that you can come and pick him up. It's just really kind of, and once again, you document that conversation as well. Now,
do you make declarative statements like that, or do you say he appears to be, or we,
I think
he's
you can
acting
say
as if
we are concerned, he appears to be, we decide to not proceed with the appointment today, and then just have that degree of clarity.
Yeah, I like that.
Yeah. Well, you speak a lot about how you want to be respectful and have sensitivity for people.
Yes.
And I can see that you don't really come from a place of judgment. And when you're making these decisions, you're just making the best decisions. So if you want to tell us about, in your career, what's brought you to have that real dedication to sensitivity?
Well, in my background, as you know, I work at a medium security correctional facility where the majority of my patients have very significant substance use histories. And when I first started there, I clearly, was a young dentist. I was very naive. I was treating patients who were relatively young with just generalized advanced caries. I thought, must be eating a lot of candy, drinking a lot of soda. But I was seeing, patterns of decay that I'd never seen before. And then I finally said to my patients, what are you putting in your mouth? Why do you have so many cavities? And they told me they were using methamphetamine. And because I was naive, I'm like, oh, okay, well what's that? And so I'm first and foremost really grateful to my patients because they did provide me with, I think, my first education around drug use. They were very willing to share information with me. In fact, they almost felt like relieved that somebody was interested in having these conversations with them. I would ask them, when did you start? How does it make you feel? Why do you use it? How does your family feel about it? And I've heard so many different stories of patients cry in my chair about their drug use started when they were 5 years old, the struggles that their family have had around it. I've had the opportunity to high-five my patient who was celebrating her 30th day of sobriety. And also just hear their stories. I mean, they're not just addicted. They're not just, I don't like that word addict because it's not appropriate, but these are someone's mom and dad. These are someone's brother and sister. This is someone's husband and wife. They're much more than the disease of addiction. And so I think what's happened in our society is that addiction has such a stigma, such a negative connotation that nobody really wants to talk about it. And these individuals are suffering with a high degree of they're suffering in silence. They're suffering in isolation because addiction is a very isolating disease. And so what I want to do, I think, compassionately is have conversations, not just with my patients, but also conversations with individuals who don't have a substance use disorder to create that degree of sensitivity and compassion. Because at the end of the day, you will not find a single person whose life has not been affected by addiction. Okay? 1 out of every 10 individuals has a substance use disorder, 43.7 million Americans in this country, 275 million people worldwide. So you don't have to look too far to your right or to your left to know someone who has a substance use disorder. I have, when I spoke yesterday, I had people coming up to me crying, sharing their own personal experience with that. And so I don't want there to be judgment around it. Judgment is not going to create treatment. It's not going to help create recovery. And I think the difference between life and death is really the stigma. The stigma is what is that link. And we need to change that stigma into something that's just more understood, more patient, more, I don't want to say accepting, but we have to go from being so negative about it to understanding these are people with a disease. These are people who are suffering. No one smokes marijuana for the first time, has that first drink, and says, when I grow up, I want to become addicted.
Yeah.
It's a brain disorder. And so I really want there to be a higher degree of sensitivity and compassion around it. Because once again, all of our lives have been impacted at some level with someone that we know, someone that we love, who is addicted.
Speaking of stigmas, Doctor, it's one thing that I've been thinking about for this last 6 months. When was the last time? No, it's been a year, actually, I think, since we talked last. Is the chronic substance abuse versus like the binge episodic. Are you seeing are there research on that being essentially equivalent in damaging to the bodies, or is there a better way of substance abuse? But I mean, is there? I mean, because I feel like. Okay, we're not throwing all the dental people out under the bus, but every time we come to a conference, there's a lot of drinking.
Yes,
right?
yes,
a lot.
Right.
And so is it, if I just do it every conference, we're good? Or is it, there's no...
So, to answer your question, sure, there definitely is research that has not been something I've focused or really studied on. But clearly, I think you're asking a couple questions. The first question is, I think with binge use, it implies a deeper problem.
Sure.
So, for example, I don't drink, I don't use drugs, but I wouldn't be at this conference slamming down 5 cocktails.
Yeah.
Right? Because that's just not something that I do. So I think the binging is a symptom of a more underlying situation. The binging might be the event, but if someone's having that degree of intake, there usually is probably an underlying substance use problem. I've been doing some work on the concept of harm reduction and the role of the dental professional in harm reduction, because really a lot of the thought process now in terms of treatment is not abstinence, because we know that in terms of like a behavior model, the stages of change, is that oftentimes the stage of change was looking at the goal of abstinence or termination of the problematic behavior. And the reality is that when you're dealing with addiction, it has all these entry and exit points: relapse, recovery, repeat, relapse, recovery, repeat. And so if we're looking at abstinence as the end goal, we oftentimes, as a result of that, are having a lot of people lose their lives.
Oh, yeah.
And so harm reduction is more trying to, for individuals who may not have that goal or may not be capable of getting to abstinence, how do we get them to adopt a use pattern that's not going to be potentially lethal? And that could be looking at, the use of like safe needle exchange programs, naloxone distribution programs, things like that. So it's really kind of been a shift in the mindset for, I think, addiction treatment, with the goal not being abstinence, but also just looking at harm reduction issues.
I think we have our part 3 agenda is harm reduction. I wrote that down. Like, we're going to talk about that. Doctor, thank you so much for being here. It's always a pleasure to speak with you. Any last messages or anything that you wanted for the audience?
I think, just once again, this isn't everyone's practice. And that is so important to understand, that it's not just in an urban setting, it's not just in the jail setting, but everybody, no matter where you practice, how long you've practiced, the location of your practice, where you trained as a dentist or hygienist or assistant, there are patients in your practice who have a substance use disorder. We are a profession that is so communicative with our patients. We see our patients multiple times, and we have an opportunity to educate all of our patients about the oral effects of addiction. We have the ability through that education to possibly prevent someone from ever using a harmful drug. And when we've done that, we have the potential to possibly save or change the trajectory of somebody's life. And that's better than any margin, any clean, surface that we can do. We have the ability to really change people's lives.
I love it.
Wonderful.
If anyone wanted to reach out to you, what's the best way to contact you?
So you can go to my website, which is drronnibrown.com. There's no E in that, so it's RONNIBROWN.com.
Sound like you forgot how to spell your last name. I loved it. All right. And we'll have that link in the show notes too, everyone. Thank you again so much for being here.
My pleasure. My pleasure. Thank you.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.